Yeah, it just saves your computer if you're at
Yeah.
home.
All right.
Wait, I just want to make sure they can hear us. Okay, you should be able to. You're recording. Okay. Happy Friday. It's a real pleasure to have Dr. Laurence Klotz address us about the work that he's been doing and we've been doing in active surveillance. Looking back, this has been a program that has spanned 30 years. Our first patient in the program was actually diagnosed in 1995. And I think it's really no underestimation to say that Laurie has really changed the practice of management of low-risk prostate cancer around the world. There's some fierce debates between him and Pat Walsh, who can maybe regale us in some of his stories. Um, Laurie is known to all of you. He is a tour de force academically. More importantly, he's a great guy and probably one of the best storytellers I've met in the world. So you're like the Dos Equis of the academic world, Dos Equis guy of the academic world. No gentleman tells or reveals his number. Laurie's citation has got to be well over 500, but he'll be modest and deny that, I'm sure. If you look at his top five, it's about he's really been prolific in the GU space. The number one is was targeted biopsies with the Precise and Precision programs, then the Selenium trial Select, and then the next several are active surveillance, and active surveillance. So it's a real pleasure to have Laurie talk to us about MRI and in terms of a prognosticator for today. And I just actually want to briefly mention that Anil Kapoor passed away 2 years today. So
Mm,
just thoughts to Dr. Kapoor and
mm.
his contributions as both a friend and an academic leader. So Laurie, over to you.
Thanks, Andrew. And that is high praise indeed. I'm not sure I deserve that, but I appreciate it. So, yeah, um, first of all, let me just say I really like the opportunity to speak at the citywide rounds, and I just encourage us as a community to do this on a very regular basis. I think it's really valuable, and it's particularly important, I think, for all of us to be familiar with what each of us is doing. We don't present to each other enough, and I often only learn about the research that's going on in Toronto at international meetings. So what I'm going to talk about today, called Genomics, Natural History of MRI, Visible versus Invisible Cancers, Implications for Clinical Practice, uh, and just disclosures. I've got research support from Exact Imaging to make high resolution micro ultrasound device. I'm not going to talk about that, but it is an imaging device. And I've had clinical trial support from OICR and CCS for a couple of these large randomized trials, which probably people are familiar with. So my talk is a combination of review of recent developments in radiogenomics in the natural history of visible versus invisible cancers, some data from our own active surveillance cohort that's relevant to this story. And I'll just emphasize Andrew's point that this active surveillance registry has been a phenomenally productive thing. It's been very collaborative venture between Andrew and Danny Vesperini and myself for many years now. The gift that keeps on giving. And then some conclusions from all of this and observations. I think you'll see, I think what we've learned from the radiogenomics has a lot of ramifications for day-to-day clinical practice. So first of all, the story of systematic versus targeted biopsy, and this is a systematic review. Notice it's almost 7 years ago. At that time, there were about 15 trials reporting the results of patients who had systematic plus targeted biopsy. For each one of these trials, you see on the left, clinically significant prostate cancer. The right-hand bar is the diagnosis rate with systematic. The middle bar is targeted. The left-hand bar is total. And you can see for each trial, there's consistently a 10 to 15% delta that systematic adds to targeted. And that's, I think, very consistent and widely accepted. So concern about these invisible cancers that are only diagnosed on systematic biopsy drives a lot of interventions and perspective. So in men who are having targeted biopsies, pretty much standard of care is systematic biopsies as well. In men who have negative imaging, although practice varies, most people do systematic biopsies in men at risk. The concept of focal therapy, where you're treating the index lesion, there's a lot of pushback on this because the argument is most patients have multifocality. You're not treating the cancers you can't see, you're going to fail. So it's a potential deal breaker at a conceptual level. And in men on surveillance, there's no question that a lot of the anxiety that patients have relates to the idea that they have something more that hasn't been diagnosed because it's not visible. And so that kind of undermines confidence in the process. So the last 5 years has seen a very rapid, I wouldn't call it explosive because there aren't that many studies yet, but it's ramping up dramatically. Studies that look at the correlation between very granular assessment of MR pixel appearance and basically genomics or genetic alterations associated with those appearance. So here's a kind of summary of this whole story. It's whether a cancer is visible or not is a polygenic trait. The genes are related to stromal associated genes, cell adhesion molecules, cellular organization, not surprisingly. If you look at the results of genomic tests like Oncotype, Prolaris, etc., they all are higher score associated with higher PIRAD score, again, not surprisingly. The hallmarks of nimbosis, this is a recently described term. Nimbus clouds are storm clouds. Nimbosis refers to all the adverse features of aggressive cancer, adverse pathology, molecular genetic instability, etc. Nimbosis hallmarks predict for highly visible lesions. Loss of PTEN, for example, has been associated with a higher PIRAD score. And on the other side of the coin, by and large, invisible, there we go. Mouse is too sensitive. Invisible lesions tend to exhibit minor or no genetic alterations that looks very similar to benign prostatic epithelium. So the implication of all of this is that the invisible cancers, even if histologically they have some elements of pattern 4, that they are genetically indolent, and therefore you don't need to worry about them. And this has a lot of ramifications. And part of the story is a call to, we've used the rubric clinically significant, basically meaning any pattern 4. But you'll see, I think the data is very convincing that we should redefine what we call clinically insignificant to incorporate imaging. So this is a summary of probably the 5 most important radiogenomic papers. You can see they're all published with the exception of the Lee paper, which is 2018, really one of the first, but the field has moved on pretty rapidly. They're all within the last couple of years. I'm just going to go into this in a little bit of detail. So this is the first one, or one of the very first ones. Genes involved in prostate cancer progression determine MR visibility. You can see the heat map does disaggregate invisible versus visible pretty well. If you look at the families of genes that are altered in visible versus invisible, they're very familiar, and you'll see that's a story that keeps reappearing here. Cell cycle regulation, mitosis, cytokine regulation, cytoskeleton organization. A lot of genes that we know are altered in higher grade and more aggressive cancers are associated with visibility. Here's the 4 genes that really stood out in this early study, and the conclusion: genes involved in cancer progression influence MR visibility. This one is one of the best. It's like a year and a half old, from Scandinavia. And this is just the families of genes that are altered in visible versus invisible. And if you go down this list, for those of you who follow the molecular genetics of prostate cancer, there's a lot of very familiar looking gene families: interleukin regulation, DNA methylation, interferon, mitosis regulation, and so on, associated with visibility. And there again is the conclusion: visible cancers harbor a signature associated with more aggressive phenotype, and vice versa. And sampling MR visible lesions with target biopsy should be sufficient for accurate risk stratification. Another one, I'm not going to go into these in much detail. It's just to get the kind of the overall story. This is transcriptomics. On the y-axis, you see different ways of analyzing MR pixels. Kurtosis is a term that refers to essentially the degree of granularity of the appearance of the pixel. And again, there's pretty much disaggregation according to gene expression. You can see here things like STAT6, EGF receptors in there somewhere, PI3 kinase, etc. Expression of genes associated with cancer aggressiveness correlates to MRI features. Same story. This one is hypoxia-related genes. Of course, hypoxia and cancer aggressiveness closely correlated. And here are some angiogenesis-related genes and different ways of analyzing the MRI. Again, it's the same story. I mentioned the nimbosis story. It's to me, a very kind of descriptive, nice term for everything that's bad about aggressive cancer. And this is from Rob Reiter, UCLA. SHLAP1 is an important oncogene in prostate cancer, hypoxia-related genes. PGA is percentage of the genome altered, copy number alteration. Again, each one of these disaggregates PIRADS 1 and 2 versus PIRADS 5. And adverse histology, they all segregate. This one is stromal genes, 16 patients, small number, but matched for grade T-stage PSA, visible versus invisible, reduced expression of stromal-related genes. These are acting as essentially as tumor suppressor genes, and a close correlation with visibility, stromal gene expression, and here progression-free and biochemical-free survival. So the message of the genomics, the studies are very consistent, that there's not huge numbers of them. There's maybe 15 altogether in the literature, but this is a very hot area in the field. They all show that essentially there's this correlation between genes associated with tumor aggressivity and visibility. And then there's the clinical story. So this is a great paper from Memorial Sloan Kettering a couple of years ago. 1,449 men with grade group 2 or higher having surgery. So the strength and the limitation of this paper is their surgical intervention. But this is disaggregated according to PIRADS. So the red line is PIRADS 4, 5. The orange is 3. The green is PIRADS 1 and 2, basically invisible. And if you look, for example, prostate cancer specific mortality, I mean, essentially 0 with the invisible cancers, pardon me, essentially 0 prostatic mortality in the PIRADS 1 and 2, metastatic disease, one case, I believe, or 2 cases out of 1,449 patients. So really pretty compelling. Again, these patients are treated surgically, but the implication is that the invisible cancers had an indolent course, were cured in virtually every single case. This is our data. So this slide hasn't been published yet. It's in the process of being written up and submitted. This is our latest analysis. I believe this is the 4th time we've gone back to this data set. The last time was quite a while ago. So this now shows, first of all, overall, this is actually metastasis-free survival out to 24 years, which is pretty remarkable, as Andrew said at the beginning. Been a long-term project. We have decent numbers out to about 20 years. And, there's no question the metastasis rate is creeping up here. It's around, I believe the absolute number is around 5 or 6% at between 15 and 20 years. Little sobering, not surprising, perhaps. But here's what is the real message. When we disaggregated the cohort by time before and after 2013, what happened in 2013? We incorporated MRI formally into the protocol. So every single patient started getting imaged either before or after diagnosis. And look at that red line. Since we did that, we don't have a single patient who has progressed to metastatic disease out of about 450. Now, you see here it's out to 18 years. How is that possible from 2013? This does include some patients who were diagnosed prior to 2013 and were incorporated, even though they didn't get their MRI perhaps for a year or two after diagnosis. When we pull out the patients to avoid some length time bias, when we pull out those patients, it looks basically exactly the same. So one message is that incorporating MRI into an active surveillance protocol really seems to work in terms of reducing what is already a low rate of metastasis, but not zero. We've always had somewhere around between 1 and 3% metastasis rate and mortality. It went to zero since we incorporated MRI, and presumably what's happening is we're identifying these aggressive cancers that are mostly anterior cancers. That was some work that Nathan Lawrence and Neil Fleshner did about 5 or 10 years ago, the PEAT cancers, that those are now being identified in MRI, biopsied, high-grade cancer treated, whereas pre-MRI era, they would be undiagnosed because they were kind of out of reach of the transrectal biopsy needle and led to an adverse outcome. And then this was a sub-analysis of this, which just got published last month. This is the results of our active surveillance cohort according to the PIRADS score. So the blue line is PIRADS 1 and 2, green PIRADS 3, red line PIRADS 4 and 5. The remarkable thing is that the PIRADS 1 and 2 essentially had this is grade progression, just grade progression. None of these patients have progressed to metastatic disease. That's the data that I just showed. This is grade progression, and we had a handful of patients at the very beginning who were upgraded despite having invisible cancers. But since then, nothing. And just keep in mind, back in the mid years of the last decade, the whole community was on an MR learning curve, and you have to wonder, were some of those so-called MR invisible cancers really invisible? We haven't gone back and re-examined those, but you kind of wonder if those early cases do reflect the learning curve. But look at how stable that has been since then. Pardon me. And in contrast, so the rate here is 5% of patients upgraded in the invisible cancers versus 52% at, I believe, 10 years in the PIRADS 4 and 5. PIRADS 3 here is obviously intermediate, looks more like PIRADS 4 and 5 than 1 and 2. In our cohort, this group did have a fairly significant rate of upgrading, around 35% at 10 years. So this is really, I think, lends a lot of support to the idea that the invisible cancers, whether it's in the active surveillance setting or in the undiagnosed patient, really have an indolent course. Here's some other data to support that. This is also a surveillance cohort, visible versus invisible. It's essentially the same story. This is from Europe. The difference between visible and invisible is not as great as it was in our cohort. You can see here, this is progression-free survival or death The brown line is the grade group 1 invisible. The blue line is grade group 1 visible, and so pretty decent separation between those curves. Time to treatment, it's the same story, so it's kind of the same message, maybe not as clear cut. So the concerns, if you're going to promote this idea, what's the downside? First of all, how prevalent is the missed aggressive invisible cancer? I'm going to try and answer each one of these with some other data. How prevalent is the missed aggressive invisible cancers? We know from the data I showed right at the start, targeted versus systematic, that you do get these cases. Not very common. I'll come back to this. What about adverse variants? There has been a suggestion that these variants like IDC and cribriform are less visible. That would potentially be a deal breaker. This one we don't have much data about yet. Can confirm that the idea is you're going to miss some aggressive cancers, few percent, but you follow the patient, and because they're aggressive, therefore they harbor the genetic alterations associated with visibility, and that they'll show up over time. And that's something that needs to be demonstrated. Presumably this will come out of other large-scale surveillance cohorts where patients are being observed over a long period. And then the other side of this coin, if you accept that cancer visibility is associated with aggressive genetic alterations, what do you do with the PIRADS5 patient whose repeated biopsy only shows grade group 1? Does that patient have an aggressive cancer despite the favorable histology? And I don't know what the answer to that is, and the practice here varies. In my practice, and I believe also my colleagues at Sunnybrook who are involved with the surveillance cohort, we are not yet treating these patients just based on the MR image. We still manage them until they're upgraded. We watch them like a hawk, but I know there are in fact some people in town who treat those patients with definitive therapy just based on the imaging, despite being grade group 1. So here, first of all, just a comment about what is the natural history of untreated grade group 2 cancers, because most of the cancers that are being missed, not all, but the majority are grade group of so-called significant cancers are grade group 2. And I quote this to patients a lot as we're having this discussion. This is from the VA a couple of years ago, 10,000 patients on surveillance almost, and about 1,000 with intermediate risk, of which 773 were grade group 2 on surveillance. So it's a very large cohort. It does suffer from some of the limitations of VA studies, but here's the results. At 10 years, the cause-specific mortality 3.7%, the for favorable intermediate risk, and the metastasis rate about 10%. So that's still pretty high. It's really too high for I would say a management strategy for low-risk disease. But what it tells you is 90% of these patients at 10 years still had not had progression. So the message is the majority, even the vast majority of these grade group 2 patients have very indolent disease. Not all. This is a study just published, New England Journal. This is an update of the Swedish screening study where they basically screened the entire population between age 50 and 60, and they randomized the patients who had a PSA above 3. They all had an MRI. They randomized between systematic with targeted if there was a target versus targeted only. So this was really a large-scale test of the value, the incremental value of systematic on top of targeted, and no difference in clinically significant prostate cancer. They found a lot less grade group 1 in the targeted only. And I think the key metric that doing only targeted resulted in delayed diagnosis of grade group 2 or higher, and mostly grade group 2, in 0.3%. I mean, really an insignificant number. So another study really supporting abandoning systematic biopsies. This is another recent study a couple of months ago. Men who had negative MRI, no biopsy, with some decent follow-up. This is kind of similar to what we've done with the PRECISE study, and we're going to have actually 8-year follow-up reported in the next couple of years. We've had a long-term follow-up component to that study. And there's the number: 4% of patients at 3 years had significant prostate cancer with a negative MRI. And most of these had some, or all of them, in fact, had some red flag, either very high PSA density, strong family, or other predisposing risk factors, family history or race, and so on. So again, if your strategy was to pull out the patients with negative imaging who really looked otherwise high risk and biopsy them, it would have been 0. And then this is another Hugesson New England Journal study from a couple of years ago. Probably most of you are familiar with this. Targeted biopsy only versus targeted plus systematic. This is the earlier publication from that same study. And there were only 9 men out of the total cohort was 18,000. And I think about 5,000 who were actually biopsied. Only 9 had significant cancer, so-called, on systematic biopsy. They were all grade group 2. They're all managed with surveillance. So essentially, the systematic biopsy didn't contribute anything to the management of these patients. What about the adverse histology? We've made a contribution. This was Sangeet's initiative, published just recently from the PRECISE study, which was the study of systematic biopsy versus MRI plus targeted. If there was a target, and we looked at the impact of adverse histology, the rate of adverse pathology was higher in the men with a target. In other words, we saw absolutely no evidence that these were less likely to be visible. In fact, they were more likely to be visible. And I think that whole story of adverse histology being less likely to be seen on MRI has been put to rest. And other people have reported this as well. And then finally, another aspect of this is it really looks in retrospect that a lot of these studies from the previous decade comparing systematic to targeted reflected the learning curve. And there's so many sources of error with fusion targeted biopsy. We saw that with the ASSIST trial that was done in Ontario, that there really is a very relatively steep learning curve and many potential sources of error. Lesion identification can be incorrect, co-registration, patient can move so that what you think you're targeting has now moved, and so on. Clearly, experience addresses a lot of this. But the evidence, there's pretty solid evidence that off-target biopsies likely account for a lot of these cases where the target was negative, the systematic biopsy was positive. This is one study from UCSF just reported last month that basically showed this, that the figure, instead of being 15% of significant cancers diagnosed only on systematic, it was 5%. And of those 5%, only 4 in 1,000 were grade group 4 or higher. And the conclusion of the study: no need for systematic biopsy. So I think this kind of paper is relevant because it shows, with experience, with better reading of the MRI, the MRIs are also better. I'm going to come back to that in a second. This figure of the relatively high rate of significant cancer only on systematic biopsy drops pretty dramatically. And the conclusion of their study, no need for systematic biopsies on men on surveillance. And then another piece of this whole story is that MRI is improving rapidly. First of all, AI, we're just kind of at the dawn of this AI era of image interpretation. But this was a study that came out last year, the performance of AI, and AI actually performed a little better, not much, but a little better than 62 experienced radiologists. And this whole area is clearly advancing radically. So MR interpretation is getting automated and better. And then the technique of MRI is evolving. So this is 8 different novel ways of interpreting MR images. Frankly, I don't understand what most of these are. It's just a list of them. But each of these has the potential to kind of move the needle forward in terms of more accurate identification of significant cancer. This is just one example. This is called restriction spectrum imaging. And you see here, there's the cancer on the right. There's the ADC map. So it's kind of maybe not. Here's the RSI, restrictive spectrum imaging. It shows it much more unequivocally. And this is just one example. There's another one on the bottom where it's hard to really tell from the ADC and the T2, but you really see it clearly on the RSI. And just one example. So this is all kind of emerging into the zeitgeist of MR interpretation. So finally, this is the concept of image-based management. What it means is don't worry too much about what you can't see. And to put it into context, think about all the other tumor sites that are out there. They're all image-based: brain, lung, liver, pancreas, kidney. We don't do systematic biopsies of the kidney. Colon, they see the lesion. Ovary, uterus, testis, bladder. We manage based by and large on image, either on radiologic imaging or endoscopic imaging. Why are we so different? We didn't have an effective way to image prostate cancer until roughly 20 years ago, when MR emerged. So the diagnosis was based first on the sextant biopsies. That was like 40 years ago, then moved to 12 core. For a period of time, there was saturation biopsies were popular. I never thought that was a good idea, but a lot of people did it. And so we've kind of evolved based on these blind systematic biopsies because we didn't have a good way to image. Well, now we do. And this radiogenomic and clinical data support the idea that image-based management of prostate cancer, like just about every other cancer, makes sense. So this is great insights in history. The wheel, Pythagoras, Newton, Copernicus, Ada Lovelace, programmable machine from the 19th century, female mathematician, E equals MC squared, etc. And I think, speaking a little tongue-in-cheek, but cancer visibility determined by genetic alterations associated with cancer aggressivity, and invisible cancers lack these alterations. It's a very profound concept and should have a lot of implications in terms of how we manage prostate cancer from day to day. So perhaps this is a little bit of hubris to stick this insight onto the list, but I really think it belongs there. Obviously, I feel fairly passionately about this topic. I've had these 2 publications recently, and then the most recent one is the one I showed earlier of our active surveillance, visible versus invisible experience. So the story is still a little bit incomplete. We need to confirm that the uncommon, invisible, aggressive cancers that we know we're going to miss once in a while will show up over time and still be curable. The evidence suggests that that is true, but we need more, because that's obviously a very critically important part of this whole piece. more radiogenomic studies. This is just the dawn of that era. There's at least 10 large prospective active surveillance databases out there. The Prius one alone is more than 10,000 patients now. We need to, those folks need to interrogate their database for the data on visible versus invisible cancers, analogous to the one that we just published, but clearly more is required. There's other ways to image. We know about 20% of patients with invisible cancers on MRI. You can see it on microultrasound, grade group 2 or higher. That's been published by several European groups. What does it mean to be visible on one and invisible on the other? What are the genetic alterations associated with that? We don't know. And of course, PSMA, which is the emerging giant. You're probably all familiar with the Meisner study that showed that cancers that were visible, they had 25 patients with targets seen on both MRI and PSMA. They did radical prostatectomy without biopsy. 100% of them had grade group 2 or higher. So, PSMA plus MRI positive obviously is telling us something about the biology of those cancers. What about PIRADS3? There's in our data set, they looked more like the PIRADS 4 and 5 in terms of likelihood of upgrading. There is one or two publications showing that microultrasound negative PIRADS 3 has 100% negative predictive value for no significant cancer. So, there's a few ways out of this dilemma, but that's clearly one of the conundrums. And then I mentioned this issue of the MR invisible cases with high genetic risk scores that are low grade on biopsy. And there's one study, 17% were intermediate to high risk by Decipher. I don't know. This is one of those cases, one of those situations where you have disparate data from different ways of assessing cancer aggressivity, and that's something that has to be worked out. So to conclude, just a summary, these MR invisible lesions, all the evidence is that they are in the vast majority of cases genomically and clinically favorable and indolent. The exception is the very small lesions that are high grade and aggressive and too small to show up on MRI, but we believe that they will show up eventually with follow-up and still be curable. These invisible cancers, even if undiagnosed, pose little threat to the patient. That's where the clinical data to support this concept comes in. Patients drastically prefer monitoring with imaging rather than biopsy. That's kind of a no-brainer. And this approach, image-based, has many advantages in terms of the burden of care, fewer biopsies, fewer insignificant cancer cases diagnosed. If you don't do systematic biopsies, you find about 50% less grade group 1 cancer. Cost goes down, psychological benefits in terms of the confidence that patients have of being on surveillance, and less diagnosis of insignificant cancers, I mentioned. Thank you very much.
Laurie, that was great. I always learn something new when I do talks. So after 25 years, I think it's like renewing my marriage vows with you. So I appreciate everything you do for us and raising the bar. So I don't know if you can see the Q&A. There's one question from Dr. Tagger. So Dr. Taggers, I don't know if you can see that, Laurie, but would you suggest all patients get an MRI prior to biopsy? Just a reminder to everybody, it is the CCO and ASCO standard as well as probably EUA. I don't have data on this, Laurie, but do you have a feeling like how many patients? My feeling is very few patients have access to MRI before their definitive biopsy. But what's your sense on the ground in your clinic?
Just to reinforce, imaging before biopsy should be the standard of care. I would say is the standard of care, and we certainly do that here. Now, it's imaging, not necessarily MRI. So I'm a big advocate for high resolution micro ultrasound. You may be aware we exact imaging, which is a Toronto-based. I mean, this micro ultrasound is a Sunnybrook invention, and the exact imaging is the Toronto-based company. This is going all over the world now. We just have completed a prospective randomized trial in men at risk for prostate cancer comparing MRI with conventional fusion targeting to high resolution micro ultrasound with targeted biopsy and plus systematic and plus to the combination. It's going to be presented actually by me at the EAU in Madrid in a few weeks. And the results are embargoed, but I'll just say I think it's going to be a pretty high impact trial.
Awesome.
In my view, it's comparable and it has a lot of advantages, one-stop shopping, no contrast, etc. But I mean, clearly patients should have imaging before biopsy, and there's an issue of MR access and micro ultrasound one way to deal with that, and obviously increasing the MRI resource to make it available to patients.
Yeah, I think if the exact view ends up being equivalent or non-inferior, I think that'll be a game changer because it's a cheaper equipment and there's no shielding requirements. So Han mentioned, can you see these questions, Laurie, or do you want me to read them?
Hang on, let me just.
If you click on the Q&A, you should be able to see them.
I'm
happy to help with.
I can see it says chat. Hang on, Q&A.
So
Here
Han
we
was
go. Is there
talking
anything
about,
interesting about the PSA levels in men? They're not really. The question is, sorry, is there anything interesting about the PSA levels in men with these MR invisible cancers? Their PSA distribution is pretty similar. I mean, they have more favorable cancers, so by and large, you wouldn't expect dramatic elevation in PSA with these patients, but overall the distribution's about the same. The ultrasound is often operator dependent, may not be widely available. What are your thoughts on that? So that's a big thanks, Aman. That's a big story. Obviously, whoever is doing the high resolution micro ultrasound needs to be capable and needs to take the time to do it properly. There is data on the learning curve, and for people who have experience with prostate ultrasound, the learning curve for identifying abnormal lesions is quite short, about 20 cases. There's a longer learning curve, which is to learn how to identify the non-significant lesions so you don't bother biopsying them, but that's less critical. That just means a few extra biopsy cores. So yeah, I think, and it's taking off. I can tell you that the micro ultrasound is now being distributed all over the world. They have a co-marketing arrangement because it's a small company with EDAP, which is a the worldwide French HIFU company, and it's been a good collaboration. So they are in basically every country in the world just about, and in those countries where there is really limited access to MRI, there's huge interest, which is not surprising. Hands. I struggle with, I should get after radiation. I have no idea about the impact of radiation on this story. I think, I don't know, Hans, it's a good question, whether post-radiation patients are the same. Probably they are, but I don't have any data to support that. So I guess my inclination would be to continue with this principle of just doing targeted biopsies. The problem, of course, is you get artifact from treatment, whether it's radiation or whatever, HIFU, TULSA, etc. And so my practice, for what it's worth, is to really do a number of systematic biopsies, not necessarily 12, but not to rely so much on the imaging just because of the problems of artifact.
Laurie, maybe I'll just ask you a question as the chair prerogative. So very impressive data for invisible tumors on MRI, like PIRAS 1 to 2. Should we change our follow-up frequency or biopsy strategy frequency based on that? Like it's a pretty compelling story now,
Well,
and
I
none of
think
our
so.
patients like our biopsy. So
Well, I think,
do
well, I'll
we need
tell
to
you,
be
we are,
biopsying these guys?
so we are, as you probably know, we already have de facto because uh, the data I showed that was just published in Prostate Cancer and Prostatic Diseases as was rejected by 2 journals and went through 10 revisions before it was finally accepted. And the reason is because we didn't do nearly as many biopsies in the as a group in the MR invisible cancers as in the MR as when there was a target. So that created the the possibility of ascertainment bias. We're doing more biopsies in the MR positive. The counter argument, which eventually was accepted, was that you've got long enough follow-up that should account for whether you've got a lot of aggressive cancers that you're missing because you're not biopsying the patient. They should show up eventually. I mean, how long do you have to follow patients before saying, okay, we can be pretty confident they don't have an aggressive cancer that we've missed? Um,
Agreed. So, but
yeah,
so I'm the same. We don't biopsy. So I don't
yeah,
biopsy patients that are negative or have stable
yeah.
disease. But should we be imaging them less frequently?
Oh, if they're invisible.
Yeah.
Yeah, that's
You showed there was basically a plateau on
so
that curve, right?
yeah, I think so. I mean, I know our practice varies. My practice at the moment is to do MRI every 4 years in
Okay.
the average patient, and I do micro ultrasound every 4 years. So they get 2 years between each imaging modality, kind of alternating. Uh, because I think they're complementary, those two modalities. But yeah, probably every 3 or 4 years is about right for the average patient.
Great. Follow-up question. So let's talk about the patients with PIRADS 4 to 5 disease. They're more aggressive. I think you suggested, should
Yeah.
we be treating these patients, or maybe we should be doing something else? Like there was a presentation at GUASCO talking about microbiome interventions, and there's a paper just came out of JCO talking about increasing omega-3s and decreasing omega-6.
Hmm.
So we've been talking a long time about nutritional interventions
Right.
or
Well,
uh,
so you're talking about the PIRADS 5 with grade group 1. Is
yeah,
that,
exactly. So like, should we treat them or should we do something else? Like we talked about it, but
well,
is it
so
time? Is it
yeah, I
time
think
for us to
so. First of all,
intervene?
surely those patients who aren't that common, um, that's first of all molecular biomarkers, which I don't know about other people on the on this call, but I hardly ever request molecular biomarkers like Prolaris or Oncotype. But surely that those are the patients who stand to benefit. I mean, I think if you have PIRADS 5 and Oncotype shows very high risk cancer, if that was me, I think I would want to be treated.
Yep.
And of course, the question is, have you missed the higher grade cancer, or is it just a kind of unusual? I didn't show this, but Matt Cooperberg published about 4 or 5 years ago this large series with genomic alterations according to disaggregated by grade, and 2% of the grade group ones were in the highest um, the worst quartile of genetic alteration. So you've got these rare cases that really look terrible genetically, even though they're grade group 1. They're probably going to be grade group 2 or 3 tomorrow. But you identify these cases. There's always the outliers that you should bend the rules for. So I kind of agree with that. Something further.
And I also think, like all these studies are talking about like a single point of care interaction. And I think the benefit of our program is that we watch patients serially and re-image, to your point,
Right.
whether it's with high frequency ultrasound or MRIs or both. And so I think if there is some bad biology, we're going to find it maybe next time, right?
Right. Right.
The
Well, that's
window
the
is,
idea.
I think the window, and I think I'm very compelled also by that, the MRI data, era data that we have.
Yeah.
The fact that, and patients are very reassured by that. Now that we
Right.
have almost nobody, I think we had one case. If we went back, I think Danny had one case, but he had a very rapidly rising PSA in his MRI. In the MRI era, we found disease, but
Right.
yeah, it's almost zero. So
Yeah.
um, there were some technical issues. Lori, apparently Urban did get online, but had trouble
Oh,
initially. So this is not a
that's too bad.
reflection of the quality of the talk or the
Right.
message that you're sharing with us. So I appreciate you
All right.
recording this, and if you send it to me or Antoinette, we can circulate that to
Okay. Great.
because it was a really great talk. And so thank
Okay.
you so
Thanks.
much for taking the time and bringing us up to speed.
Okay.
Like I said,
Great.
I always learn something every time I hear you speak. So keep it
All
up.
right. Okay. Thanks, folks.
Have a great weekend,
All right.
everyone.
Okay. Great. Bye-bye.